everyone, welcome to Try Right. This is Pack 265, myself Srija. Today in this session, you're going to learn about the CPT coding surgery guidelines for musculoskeletal system. So the first procedure is wound exploration. So this slide explains CPT codes 20,100 to 20,103 which are used for surgical exploration of traumatic wounds which are caused by penetrating injuries like stab wounds, gunshot wounds or deep punctures. So when are these codes used? So these codes are reported only for traumatic wounds where the doctor must actively explore the wound to see how deep it goes, which structures are involved like muscle, fascia, vessels or organs, whether there is bleeding for a foreign body. So these codes are not for simple cuts or lacerations that only need suturing. So why do wound exploration codes include? So the CPT codes already bundle several services, so they should not be coded separately. So the first is surgical exploration and enlargement of the wound. So doctor may extend or open the wound to see deeper structures clearly. Second is extension of the dissection, which is to determine the penetration. Surgeon dissects through the tissue layers to find out how deep the injury is, whether it reaches the muscles, vessels or organs. Third is debridement of the foreign body removal. So removal of the dead or contaminated tissue, materials like glass, metal, wood, bullets or other objects. So this debridement is included in the exploration code. Fourth is ligation and coagulation of minor blood vessels. So small blood vessels may be tied off, ligation, catheterized, coagulation, only minor vessels are included. So in exploration plus repair are both included. So these codes cover both exploration of the wound and repair of the explored area. So you do not code repair separately when it is a part of exploration. So when not to use wound exploration codes. So if the doctor performs only simple, intermediate, complex wound repair and the wound does not require enlargement or deep exploration, so then you should code closure or repair codes from the integumentary section, that is 10,000 series instead. So fifth is the major procedures override wound exploration. So if thoracotomy, nothing but a chest surgery, or laparotomy and abdominal surgery is performed, so wound exploration is considered included. They do not code wound exploration separately. And separate procedure. So what is a separate procedure concept? Wound exploration is labeled as a separate procedure, meaning it is a minor procedure. If done along with a major surgery, it is not reported separately. It is coded only when it is performed alone. So use 20,100 to 20,103 only when documentation clearly states it is a penetrating traumatic wound where a surgical exploration performed and depth and structures are evaluated. So do not use these codes for simple laceration repair, for superficial wound cleaning and routine suturing without the exploration. For example, a patient presents with a stab wound to the thigh. So the surgeon enlarges the wound, explores the muscle layers, removes the debris and controls the minor bleeding and closes the wound. So the correct coding is the wound exploration codes based upon the location. So do not code separate debridement or repair for this example. And next procedure is excision. Excision, biopsy, introduction or removal. So this combines three important CPT concepts. So let's clearly discuss about these topics. So biopsy, what it really means. So biopsy is its removal of a small sample of tissue from a living body to examine under a microscope and make a diagnosis. So what is a very important coding rule regarding biopsy? So if a biopsy is performed at the same site along with excision, repair, destruction, removal and internal fixation, so the biopsy is considered as included. Do not bill biopsy separately. Why? Because once the entire lesion or structure is removed, the diagnostic biopsy becomes unnecessary as a separate service. So there is an example. Surgeon takes a biopsy from a bone lesion. So then excises the same lesion completely in the same session. So in this case, you have to code only the excision. Do not code biopsy separately because biopsy is included in the excision. So you do not bill biopsy separately. So now how biopsy procedures are divided. So biopsy codes are selected based upon three factors. Number A, type of biopsy, whether it is a muscle biopsy or a bone biopsy. So each has different CPT code ranges. B is depth of the biopsy, whether it's superficial, like near the surface, a minimal dissection, or deep. So deep depth, it requires incision through muscle or fascia. So deeper biopsy gives a higher complexity and higher CPT code. And C is the methods used in the biopsy, whether it is an open biopsy or a percutaneous biopsy. So in open biopsy, the incision made tissue is directly visualized. In the case of percutaneous biopsy, a needle-based biopsy is done, which is done through skin. So the approach is through skin. So open biopsies usually pay more than the percutaneous biopsies as they are more complicated than percutaneous. Introduction or removal procedures. So this section refers to injecting or removing fluid or medication from the body structures. So what are the common sites mentioned? Sinus tract, tendon, trigger point, and joints. So these are not the excisions. They are the introduction or removal procedures. Next is joint procedures, arthrocentesis, aspiration, and injection. So arthrocentesis is it's an insertion of a needle into joint which is used to remove the fluid, format of aspiration, and by injection of the medication like steroids and anesthetics. And CPT codes 20,600 to 20,611. So these codes are used for aspiration and or injection of a joint or a bursa. So how these codes are classified? A, joint size. So joint sizes may be small joint, intermediate joint, and major joint. So small joint, it includes fingers, toes, 20,600 code range. Intermediate joint, it includes wrist, elbow, and ankle, 20,605 code range. And major joint, it includes knee, shoulder, and hip, which code ranges are 20,610. So next is imaging guidance. So imaging guidance includes without ultrasound and with ultrasound guidance. If it is with ultrasound guidance, you have to report 20,611 code. So if ultrasound is used, image must be documented and stored. Otherwise, guidance cannot be coded. For example, steroid injection into knee joint using ultrasound. So you have to code 20,611. So do not code 20,610 plus ultrasound separately. And codes are based on the size of the joints. So how to correctly code joint aspiration, injection procedures, especially when multiple joints, ultrasound guidance, and drugs are involved. So how joint injection codes are selected? So CPT code ranges 20,600 to 20,611. These codes are chosen based upon two main factors, the size of the joint and the ultrasound guidance. So size of the joint, they include small joint, intermediate joint, and major joint. So trigger point injections. So what are the trigger point injections, which is an important clarification. So trigger point injections, they are not coded by joint size. They are coded by number of muscles injected, not the joints. For example, injection of 10 trigger points in 10 muscles. So you have to use trigger point specific CPT codes which are ranging from 20,552 or 20,553. So do not confuse the trigger point injections with the joint injections. So single joint means it's a single unit of a service. So if multiple techniques are performed in one joint or its surrounding structures, so count it as a one unit only. So example is arthrocentesis of the right knee, aspiration of the right knee bursa. So you have to code only one unit. 20,610 without ultrasound guidance or 20,611 with ultrasound guidance. So do not code knee joint plus knee bursa separately. And coming to multiple joints, you have to code separately. So if procedures are done in more than one joint, each joint is coded separately. You have to use modify 59 if required to show distinct joints. So injection codes does not include the drug. So very important billing rule. CPT code to 20,600 to 20,611. These are procedures only. So the medication injected just be billed separately. So you have to use HCPCS level 2 Z codes for this assigning of the injection drugs. For example, provider injected 40 mg of Kenalog into the left knee. So provided aspirated 4 cc of fluid from the right knee. So ultrasound guidance is used for both. So what is the correct coding? You have to assign code 20,611 for left knee injection, 20,611 and adding modifier 59 for right knee aspiration, which is a distinct joint from left knee injection. And you have to assign the code J3301 HCPCS code for the Kenalog injection, and you have to multiply into 4 as it is 40 mg composition. So why modify 59? Because it's the same CPT code, same session but different joints. And next procedure is replantation. So what is a replantation? Replantation is a surgical reattachment of a completely amputated body part such as finger, thumb, hand and arm. So the amputated part is fully separated from the body and then it is reattached. So how replantation codes are selected? So code 20,802 to 20,838 codes are chosen based upon the anatomical location, whether it's a finger versus thumb versus hand and level of the amputation. So these are the complex microsurgical procedures involving bone, tendon, nerve, artery and vein repair. So what is the important note under replantation? Incomplete amputation. So if the body part is not completely amputated or not completely severed, so do not use these full replantation codes. You have to use the appropriate repair code, append modifier 52. So modifier 52 is a reduced service code. So for example, there is a partial finger amputation which is repaired surgically. So you have to assign code 20,802 with modifier 52. Next procedure is repair, revision, reconstruction. So first, what is arthroplasty? It's a surgical reconstruction or a replacement of a joint. So it's an open surgical procedure. So the damaged articular surface of the joint are removed in the arthroplasty. So again, it is replaced with the artificial processes. So what are the common joints for arthroplasty? Knee, hip, and sometimes shoulder and elbow. So there are types of arthroplasty. Total arthroplasty where both joint surfaces are replaced and partial arthroplasty where only one joint surface is replaced. For example, total knee replacement and partial hip replacement. So what is a coding concept under arthroplasty? So arthroplasty codes usually include removal of the damaged bone, implant insertion and joint reconstruction. What is arthrodesis? So arthrodesis means a surgical fusion of a joint. So two bones are fused together and the movement is intentionally eliminated in the arthrodesis. So arthrodesis is always done to relieve the pain or to stabilize a joint. So where is this arthrodesis performed? In the common joints which include ankle, carpals, the wrist bones and tarsals, the foot bones and also the spine. So how arthrodesis is performed? At the ends of the bones are prepared. So these are fixed together with using screws, plates and rods. So these are often combined with bone graft. And next is spine orthodesis. So spine orthodesis is a surgical fusion between the vertebrae. So this is very common in the spine surgery and the coding depends upon the number of levels. The approaches may be either the anterior approach or the posterior approach. So now how to correctly code spine orthodesis and its associated procedures and modifiers. So look for the three key things every time. So when you see orthodesis, you have to always check for three separate components. First one is approach and location, which is a base code 161 series. So this is a primary orthodesis code. So based upon the spinal region, based upon the approach and based upon the number of levels, this is a main code for fusion. And second is bone graft, 147 add-on series. So bone graft is not included in orthodesis. So code only if it is documented and add-on codes are involved, for example, autograft and allograft. So bone graft codes are add-on codes, they are never reported alone. And the third is instrumentation 167 add-on series. So these are used when hardware is placed, for example, rods, screws, plates and add-on code. So report only if the instrumentation is documented. Modify 51. So what is a modify 51? Multiple procedures, right? So when to use modify 51? So if arthrodesis is performed with another major spinal procedure, such as a fracture case, such as osteotomy and laminectomy. So append modifier 51 to this arthrodesis. Why? Because arthrodesis is considered a secondary procedure in that scenario. And next is laminectomy plus arthrodesis relationship. So what is the relationship between laminectomy and arthrodesis? So laminectomy, it's a removal of part of the vertebral bone. So it is often done to decompress the nerves and frequently performed with the arthrodesis. So what is the coding rule? Laminectomy plus arthrodesis, append modifier 51 to arthrodesis. So do not apply modifier to 51 to the bone graft and the instrumentation. Only you have to append to the orthodesis. So modifier 51 applies to orthodesis code. Modifier 51 does not apply to the bone graft as well as instrumentation, because bone graft and instrumentation, they always comes under add-on codes. So add-on codes never takes the modifier 51. And coming to modifier 62, two surgeons. So when to use modifier 62? When there are two surgeons both working as a primary surgeon and each surgeon performs a distinct part of the procedure. So this is very common in complex spine fusions, combined anterior plus posterior approaches. So always append modifier 62 to each applicable CPT code. And what are the approach procedural rules? So approach procedurals, these are coded separately only when appropriate. So appropriate or approach code applies to arthrodesis. Approach code does not apply to bone graft and instrumentation. So now what are the types of spine approaches? The first one is lateral extracavitary approach. The code ranges are 22,532 to 22,534. So this is a side approach. This is used mainly for thoracic or lumbar spine, and it is complex. It is a complete complex exposure. And second approach is anterior or anterolateral approach. This is a front or front side approach, which is very common in cervical and lumbar spine surgery. And the code ranges are 22,548 to 22,586. And the third approach is posterior or posterolateral or lateral transverse process technique. So surgery is done from the back, from the posterior side of the patient. So bone graft is placed between the transverse processes or along the posterior elements of the spine. So this is very commonly used in the lumbar and thoracic spine fusion. And the code ranges are from 22,590 to 22,634. So what are the keywords you may see in the operative notes? So understanding these terms helps you to count the levels correctly. So vertebral interspace. So what is a vertebral interspace? It's a non-bony space between two adjacent vertebrae. So it contains the intervertebral disc. For example, L4 to L5 is one interspace. So interspace is nothing but it's a disc space. And second term is vertebral segment. So vertebral segment is, it's a one complete vertebral bone. So for example, L4 alone, it's a one vertebral segment. So segment is the bone. So this difference is extremely important for coding. For example, fusion of L4 to L5. So one interspace and two vertebral segments. So we have two vertebral segments, L4 and L5. Whereas the interspace is between two vertebral segments and we have only one interspace in this example. So most arthrodesis codes, they are based upon the interspaces but not the segments. And next is spine structure, regions of the spine. So cervical spine, thoracic spine, lumbar spine, sacral spine, cochlear spine. So these are the spines of the spine regions of the body. So cervical spine. So there are 7 segments, C1 to C7. So for example, interspaces from C3 to C4, we have one interspace. C5 to C6, we have one interspace. So C1 to C2, which is very unique, there is no disc. And thoracic spine. So thoracic spine T1 to T12. There are 12 segments within the thoracic spine. So each thoracic vertebra articulates with the ribs. And lumbar spine L1 to L5. We have 5 segments in the lumbar spine. So this is very most common region for degenerative disease and fusion surgery. Sacral spine S1. We have only one segment. So this fuses with the L5 at L5 to S1 interspace. And the last is cochlear, which is a tailbone. So it's a terminal part of the spine which is rarely involved in the fusion coding. And what is interspace? The disc space between two vertebra. And what is a vertebral segment? It's only single vertebral bone. So how this applies to CPT coding? For example, posterior fusion example. Fusion of L4 to L5 and L5 to S1. So the interspaces fused here are 2 and the vertebral segments involved is 3. So code for 2 levels but not for 3. So how to correctly report the spine fusion when two surgeons work together, when bone grafts are used and when spinal instrumentation is added. So when two surgeons working together, so you have to append modifier 62 indicating co-surgeons. So if two surgeons act as in primary surgeons, each performing distinct parts of the same procedure, both surgeons report the same CPT code with modifier 62. Because both surgeons must be from different specialties or performing clearly a distinct surgical work, operative note must document separate responsibilities. So what is an example? For example, orthosurgeon, he performs discompression with exposure. And neurosurgeon, he performs fusion plus neural protection. So both report orthodesis code plus modifier 62. And bone grafting is reported separately but no modifier 62. Bone graft codes ranging from 20,930 to 20,938. They are reported in addition to orthodesis. So do not append modifier 62 to bone graft codes. Why? Because bone grafting is considered as a supportive work. It is not independently shared between co-surgeons. So for example, orthodesis L4 to L5. So you have to assign 22,558 with modifier 62. So bone graft, which is an autograft or allograft, you have to assign 20,936, no modifier 62. And then spinal instrumentation is reported separately but not the modifier 62. So instrumentation codes include 22,840 to 48, 22,850, 852, 853, 854 and 859. So instrumentation separately reportable. So do not append modifier 62 to this instrumentation codes. Why? Because CPT considers the instrumentation part of the global surgical support. This is not split between surgeons for reimbursement. And next guideline is orthodesis with another spine procedure with modifier 51. So when orthodesis is done with fracture care, laminectomy, osteotomy, vertebral corpectomy. So you have to report the orthodesis with modifier 51, which are multiple procedures. And what is the important exception? Do not use modifier 51 on add-on codes. And next procedure is bone graft. So what happens during spinal fusion? Surgeon wants to stop the movement at a painful or an unstable level. So a solid bony bridge must form between two vertebrae. So why this bone graft is needed? A bone graft provides a scaffold, growth factors, and these are the cells that promote new bone formation. So there are types of bone grafts: autograft, allograft, and bone graft substitute. So autograft, it's a patient own bone. Allograft, it's a donor bone, whereas bone graft substitute, it's a synthetic or biological material. Yeah, types of bone graft. Autograft. So bone taken from one side to another site in the same patient. So what are the common donor sites? Maybe a hip bone, iliac crest, which is the most common one, and next ribs and spinous process or lamina. So what are the advantages of this autograft? It's a best healing potential and there is no rejection risk. What are the disadvantages? Extra surgical site and there will be more pain and risk of the infection. So coding notice, allograft, autograft harvesting may be separately reportable if it is documented. Coming to allograft, it's a bone taken from a donor of the same species, which is usually from a cadaver, that is a bone bank. And advantages of this allograft is there is no second surgical site and it requires less operative time. Disadvantages, it's a slightly lower fusion rate than the autograft and there will be a small risk of disease transmission. So the coding notice, it is still reported separately with bone graft codes. And the third type of bone graft is morcellized bone graft. So in this, a bone that has been cut or crushed into small pieces. So why it is used? It increases the surface area, it promotes the faster bone healing, and it is common in the posterior lateral fusion. So this can be autograft or allograft. So what is a bone graft harvesting? So what is harvesting? It's a surgical removal of the bone graft from the patient. How it's done? Same incision as the fusion surgery or separate incision. So what are the common harvest sites? Iliac crest, ribs and spine itself. Next is instrumentation, the spinal hardware. So what is instrumentation? Metal implants used to stabilize the spine until the fusion occurs. So what are the common metal implants? What are the common devices used? Rods, hooks, screws, plates and interbody cages. So instrumentation does not cause the fusion. It only holds the spine still so fusion can be happen. And there are types of spinal instrumentation. So segmental instrumentation and non-segmental instrumentation. So in segmental instrumentation, the hardware is attached to at each vertebral level that is fused. For example, screws are placed at L3, L4 and L5. So that rod connects all the levels and it is very stronger and more stable. Whereas in the case of non-segmental, the hardware is attached only at the top and bottom. So it does not attach at every level. For example, one curved rod is fixed at T12 and L5 only. So this is very less rigid than the segmental. So these are the types of spinal instrumentation. So what are the key terms which are used in the spinal instrumentation? Orthodesis, which is a surgical fusion of two or more vertebrae. Posterior approach, a surgery done from the back. Anterior approach, it's a surgery done from the front. And DDD, it's a degenerative disc disease. Autogenous graft, it's a patient's own bone. Allograft, it's a donor bone. And morselized graft, it's a bone cut into small pieces. And separate facial incision, it's a graft taken from a different incision site. And add-on codes, these are never used alone and there will be no modifier 51 for add-on codes. And here is an example for the spinal instrumentation. So what is the first example? Posterior orthodesis of L4 to L5 for degenerative disc disease, DDD. So using morselized autogenous iliac bone graft harvested through a separate facial incision. So what is the coding logic here? L4 to L5 is a single spinal level. So the posterior fusion, it uses the posterior orthodesis code. So bone graft taken from iliac crest via separate incision. So you have to add the graft harvest code. So the codes are 22,612 for posterior lumbar orthodesis for single level and 20,937 which is an add-on code for autogenous bone graft. So why plus 20,937? Why we have coded 22,612 and 20,937? Because the bone is the patient's own and harvested through a separate incision. Coming to second example, posterior orthodesis of L4 to S1. So levels are L4 to L5 and L5 to S1. So the first fusion level is the base code. So first posterior lumbar fusion level is assigned 22,612 and 22,614 code is assigned for each additional lumbar fusion level. And the add-on codes 22,842. This is for posterior segmental instrumentation including 3 to 6 segments, and 2937 add-on code for autogenous bone graft which is a separate incision. So instrumentation codes, they are separate from the fusion codes. And third example is L2 burst fracture. So carpectomy via transperitoneal approach is done. It is followed by the anterior orthodesis of L1 to L3 and anterior instrumentation along with the structural allograft. So do not append modifier 51 to the add-on codes. So the codes are lumbar corpectomy for 6390 and 22,558, 51 is for anterior lumbar interbody fusion. As it is a different distinct procedure, you have to assign multiple modifier 51. And for each additional space, we have assigned 22,585 add-on codes. And for anterior spinal instrumentation, 22,845 code is given. And for structural allograft, 20,931 code is assigned. In the same way, example 4. 53-year-old man with post-traumatic triple D at L3 to L4 and L4 to L5. Here there are two segments. So this example is an incomplete on purpose. So you must identify the approach, whether it's an anterior or posterior approach, and the number of levels, and the graft type, and the instrumentation. So here is the core surgeons in the anterior spine surgery. So surgeon A performs the anterior exposure of the spine. He mobilizes the great vessels like aorta and vena cava. And surgeon B performs the anterior dissectomy fusion at two levels, L3 to L4 and L4 to L5. 4 levels and 2 interspaces. So uses the anterior interbody technique. So they also places a structural allograft. So this is a classic core surgeon case. So what is an important concept using modifier 62? So it is used when two surgeons of the different specialties perform distinct parts of the same procedure. So payment is split by the payer. And what are the CPT codes involved here? 22,558 for anterior lumbar interbody fusion for the first level, and 22,585 for each additional interspace, and 20,931 is for structural allograft. This is the correct coding. So for surgeon A, we have assigned 22,558, 62, 22,585, 62. So exposure of spine with vessel mobilization is integral to the anterior fusion, and it qualifies for core surgeon billing. And in the case of surgeon B, we have assigned 22,558 and 22,585, 62, 62 modifier for each. And also for the allograft. So do not append modifier 62 to the bone graft, because bone graft is not a shared work. So only surgeon B places the graft. And next is arthrodesis for spinal deformity, scoliosis or kyphosis. So what is the key rule? Codes depend upon the approach, whether it's anterior or posterior. So the number of the vertebral segments are fused. So here for posterior deformity arthrodesis, the code ranges are 22,800 to 22,804. Whereas for anterior approach, anterior deformity arthrodesis, the codes are 22,808 to 22,812. So these codes are not the same as degenerative fusion codes. And the next procedure is percutaneous vertebroplasty and vertebral augmentation. So these procedures, they are used mainly for vertebral compression fractures, osteoporosis, and tumor-related vertebral collapse. So the CPT codes are 22,510 to 22,515. So this code ranges includes bone biopsy and also includes the imaging guidance. Vertebroplasty. So what is vertebroplasty? How do you define it? It's a cement injected directly into vertebral body processes. So there is no cavity created, and the goal of the vertebroplasty is to strengthen the bone. Whereas in the case of vertebral augmentation, also called as the kyphoplasty. So here a cavity is created first, which is usually with the balloon. So then cement is injected and it restores the height plus stability. So what is the important rule? Vertebral augmentation always includes vertebroplasty. So never code both together and only report the augmentation if performed. And next is the sacroplasty. So the procedure is similar to the vertebroplasty, but it is done in the sacrum. So the codes are category 3 codes, category 3 CPT codes, 0200T to 0201T. So these are very temporary codes and these are used for emerging technology. So this is about the percutaneous vertebroplasty and vertebral augmentation code classification. So this is for today's session. I hope this session has helped you. In the next session, you're going to learn about more procedural coding guidelines and more CPT surgery guidelines for integumentary system. Thank you.